So hello everyone, let's begin with this module on chronic obstructive pulmonary disease, COPD as you call it. Well, this COPD is such a common disease. You can get COPD cases in your routine OP follow-ups. You can get even exacerbations of this COPD in your emergency department. So this is one disease you have got to know in good depth. Okay. And in the year 2019, there were certain changes in the guidelines for COPD management, which we will be discussing in this module. So these recent changes also make this topic again a more relevant one for your exams as well as your clinical practice. So let's start with COPD, chronic obstructive pulmonary disease. Okay. So first we will begin by trying to understand this entity. What is this COPD? COPD is a chronic obstructive airway disorder, a chronic obstructive airway disorder, okay? And this disorder is characterized by irreversible airflow limitation. Irreversible airflow limitation. Now I would just highlight this portion, irreversible airflow limitation, just to compare it with another obstructive disease like a bronchial asthma, where the airflow limitation is a reversible one. But here you have a irreversible airflow limitation. Okay. And because of this irreversible airflow limitation, you get the symptoms and signs of COPD. Okay. And this particular disorder, okay, your COPD is having three domains. Okay. Three domains. Now what are the domains of this COPD? It has got three domains. Let's see what are the domains. You have got emphysema as one domain, emphysema. You have got another domain, that is your chronic bronchitis. The first two are the most important ones, and you have also got a small airway disease. Small airway disease, which you call it as a bronchiolitis. Okay. Now these are the three domains. Now what do I mean by this? Okay, domains of COPD. It basically means in a COPD, different regions of your respiratory tree may be involved. Okay, and in emphysema and chronic bronchitis, though both are the COPD spectrum, the sites of involvement are different in emphysema and chronic bronchitis. Okay. So in case of your emphysema, it is predominantly your respiratory bronchiole and the alveolus that is involved. Whereas in case of chronic bronchitis, you have predominant involvement of your bronchi. Okay, it is chronic bronchitis. So it is the site of involvement is slightly different. And in case of your small airway disease also, you get bronchiolitis. So what we are going to do in this module is, we are first going to study what is emphysema, then come to chronic bronchitis, make a comparison of emphysema and chronic bronchitis, and thereby it will help us to understand the disease COPD in total. Okay. And then we will move on to the diagnosis and management. So that is going to be the discussion pattern for this module. Okay. So we will start off with the first entity. All right, are you with me? So we will start off with emphysema. Okay, we will start off with emphysema. Let's see what this emphysema is. So emphysema is a condition that is characterized by, okay, there is a irreversible irreversible damage and dilatation of respiratory acinus. Okay, respiratory acinus. Now, what do I mean by this? Okay, so for that you have got to have a basic understanding of what this respiratory acinus is. So I'll take your attention to a picture in Robbins pathology. At least some of you would be able to recognize this picture. Now this one you can see here is a section of the respiratory acinus. If you ask me what is this respiratory acinus, it is that portion of the respiratory tree that is distal to the terminal bronchiole. So distal to the terminal bronchiole, the part of the respiratory tree is called a respiratory acinus. So what are the components? It includes the respiratory bronchiole, the alveolar ducts and the alveoli. Okay, respiratory bronchiole, alveolar ducts and alveoli, that is the normal respiratory acinus. In case of emphysema, what happens is that in this respiratory acinus there is some damage to the walls, okay, and subsequent dilatation is occurring, and that is what happens. Okay, the airway dilatation occurs and that is involving your respiratory acinus. Okay, regarding these individual types we are just coming to that, just wait. So I hope the picture of respiratory acinus is very clear for you. Alright, okay, so emphysema, irreversible damage and dilatation of respiratory acinus, and this emphysema has got certain patterns. So let's see what are the patterns of emphysema. Patterns of emphysema. Okay, so there are different patterns. One is centri-acinar, or you can even call it centri-lobular pattern. Centri-acinar or centri-lobular. Then you have a paraseptal region, paraseptal. Then you have a pan-acinar pattern, and then there is a irregular pattern. Okay. Now what are these individual patterns is what we are going to see. Okay. Are you with me? So the first pattern is the centri-acinar pattern. The basis of such a classification is nothing but based on where in the respiratory acinus are you having the damage predominantly. Okay. That is, I'll just show you some pictures, okay, because when I show you these pictures it should stay in your mind, and when it comes to the exam also, rather than mugging up, you must be able to recollect, okay, this is your centri-acinar. Okay, that is why I am showing you lots of pictures in my video modules. Now what happens in a centri-acinar emphysema, which is also called a centri-lobular emphysema, what happens is that the brunt of the attack happens in the respiratory bronchiole. Okay, respiratory bronchiole, which means it's not in the alveoli. The brunt of the attack occurs in the respiratory bronchiole. Now what is the end result of that? The respiratory bronchiole walls will be damaged and it will be dilated. As you can see here, the respiratory bronchioles are very much dilated. Can you see that? And that results in the formation of blebs. You can see a bleb here. Okay, blebs. Okay. So you can see that the alveolar duct and the alveoli are relatively okay. Okay, there may be some slight affection, but predominantly it's the respiratory bronchioles that are affected. So will you agree with me if I say that in case of centri-acinar emphysema, it is predominantly the proximal part of the respiratory acinus that is involved? Proximal part of the respiratory acinus is involved. Agree with me? Okay. So the distal part is relatively spared. This is called a centri-lobular emphysema or a centri SNR emphysema. Now regarding this, I want you to remember two multiple choice questions. Number one, this is the most common pattern of emphysema. Which one? The centri SNR. Okay, very important. That is the most common pattern. Second point is that this is the pattern that is common among smokers. Okay, this is the one that is common among smokers. So centri SNR or centrilobular is the most common type of emphysema. Very clear? Okay. Now next is next subtype. Let's see the next subtype. See, the next subtype is where you can see that this is the terminal bronchiole, and you know that distal to the terminal bronchiole is the respiratory acinus. So in this pattern you can see the respiratory bronchioles are more or less paired. Okay, but you see the alveolar ducts and the alveoli, they are very much dilated. This type is known as a paraseptal emphysema. Okay, so you will agree with me if I say that in this subtype it is the distal portion of respiratory acinus that is involved. Agree with me? Distal portion of the respiratory acinus. In which one? Paraseptal. Okay, alright. So the next point or the next subtype is a pan-acinar emphysema. Okay, is a pan-acinar emphysema. Pan-acinar, which means entire acinus, which means your respiratory bronchioles, your alveolar ducts, the alveoli, everything becomes dilated. Okay, that is a pan-acinar emphysema. And sometimes you can have a irregular type of dilatation, that is what you call a irregular type of emphysema. Okay, so these are the subtypes of emphysema. Okay, out of which the most important one you have got to keep in mind is the centri SNR or centrilobular. Two MCQs I have already told you with respect to your centri SNR. There is one more point that the centri SNR is more common in the upper lobe. Okay, in the upper lobe of the lung is where you will have your centri SNR subtype more commonly. Okay, so what have we learned so far? We have learned the patterns of emphysema. Okay, the patterns of emphysema. Now, having understood, okay, this emphysema, the patterns and what is happening, now the next question, why is there a destruction and dilatation of the respiratory acinus? Why does it occur? So everything in medicine always starts with the question, why? Okay, you have got to ask why always. So why does this occur is what we are going to learn now. So let's learn the etiopathogenesis of emphysema, and I'm sure that even before I describe the etiopathogenesis, the single most important contributing factor to the etiopathogenesis, what is it? Smoking. It is smoking. Okay, that I am sure that everyone knows. Okay, it is smoking, that is the most common cause. But let me ask you one more question. Is smoking the only cause of emphysema? Mostly it is smoking. Okay, mostly it is smoking, because it is very less likely that you are going to encounter an emphysema in case of non-smokers. Okay, because this one is the most commonly it is associated with smoking. But you must understand one more point, that every smoker does not develop an emphysema, correct? Which means there may be also a role for genetic predisposition. So you can say that yes, smoking is the most important contributing factor, but there may also be a contribution from your genetic predisposition. Okay, genetic predisposition also might be there. Okay, all right. So I hope you understood what incites the emphysematous change or what triggers. But a trigger is not enough. Okay, you have got to have certain changes that happens, right? So what happens is that because of this smoking and genetic predisposition, there occurs certain inflammation. Okay, this is in fact an inflammatory process. In your COPD also, there occurs chronic inflammation. There occurs chronic inflammation. And when there is inflammation, you have got to have inflammatory cells. So yes, you have inflammatory cells taking part. You have the macrophages. Okay, you have the neutrophils. You have the lymphocytes. Okay, so different cells are also taking place in this inflammatory process. So you understood there is some trigger, probably the cigarettes smoking, and maybe the products in the cigarette smoke can act as triggers, inciting a inflammation. Now when this inflammation results, why does this damage occur? The damage occurs because in your body there are certain delicate balances, okay, between certain enzymes, like, and also various pathways. There is a balance happening in the sense that you might have a protease anti-protease balance. Okay, protease anti-protease balance is there because there is usually a good balance maintained. But if the balance is disturbed, if certain proteases like elastase act unopposed, then what happens is that there occurs destruction of the walls of the airway. Okay, so it is important to maintain a good balance of your protease, anti-protease. It is important to maintain a good balance of your oxidant and antioxidant mechanisms. Okay. Okay, otherwise what will happen? There may be some oxidant damages. Okay, so you have got to have a balance here. And also you might find that there are certain other minor pathways also. But these two are the ones which are important in this current context. So in emphysema, it is quite obvious that these pathways, the balance is broken. And that is why you will have an excess protease mediated damage. You might have certain oxidant damages to the airway. Okay, so that is what happens, and there is a destruction of the airway walls. So I will take your attention to a figure in Harrison, a simple flowchart which demonstrates the etiopathogenesis of emphysema. You see the triggers, yes, the cigarette smoke and genetic susceptibility. The effector cells, I told you it is an inflammation. So inflammatory cells are important. You have the macrophages, your neutrophils, lymphocytes, and there is a role for the epithelial cells as well. Okay, and the various biological pathways, you remember two important pathways that I have mentioned, where normally the balance is important, but that balance is disturbed here. And because the balance is disturbed here, you see there are enzymes like elastase which are released and which will cause the destruction of the extracellular matrix. Okay, and the oxidant damage also results in a chronic inflammation. The epithelial cells also undergo apoptosis, so there may be cell death. And also what happens is that, see, whenever there is some destruction of the cells, there is some dilatation, there is some inflammation. So the body will try to repair, correct? So the lungs will attempt a repair. Yes, the lung attempts a repair, but often what happens is that there is a ineffective repair. And since there is a release of cytokines like TGF-beta, which are attempting to repair, but what happens is that there may be fibrosis, a bit of fibrosis also setting in. So all in all, it is a destructive process that is happening by virtue of a chronic inflammation, and there is a ineffective repair process also. Okay, so this is what happens in your emphysema. A similar pathogenic mechanism happens in chronic bronchitis as well, but there is a slight difference on the end results which I will discuss later. But for the time being, I am sure that you understood why in emphysema a smoker develops a airway dilatation, why there is a destruction and why there is a dilatation. Okay, so I hope the why is answered. All right, very clear. Okay, So we have understood the pathogenesis, etiopathogenesis of emphysema. Now, so as to understand the disease better, okay, we understood the why of it, why it happens. Now, what is happening? What is the end result? You've got to understand the gas exchange abnormalities in emphysema. Okay, the gas exchange abnormalities you have got to understand. Okay, so let's try to see what are the gas exchange abnormalities that occurs in emphysema. So I'm going to take the example of a Sentry SNR emphysema to explain this to you. So why have I chosen the Sentry SNR emphysema? Is it because I have any special liking for it? No, it's because it is the most common pattern of emphysema. Almost 90 to 95% of cases is a Sentry SNR emphysema. So let's learn with that as the prototypical example. Okay, so we are trying to understand the gas exchange abnormalities. Now let's see what happens here. I've already explained to you there is formation of various blebs in the respiratory bronchiole, and whenever you have the blebs in the respiratory bronchiole, what happens is that in the respiratory bronchioles all this air will get collected. So will you agree with me if I say that there is air trapping happening? Okay, there is air trapping. Okay, so where is this air trapping happening? It is happening in the respiratory bronchiole. You agree with me or not? So all the air is getting trapped in your respiratory bronchiole. Okay, so there is some destruction of the bronchioles, respiratory bronchiole, there is dilatation. So enough air is not reaching the alveoli. You know that the alveolo-capillary unit is very important for the gas exchange. So when the enough air does not reach the alveoli and it is not available for gas exchange, you tell me what will happen to the PaO2? There will be a decrease in the PaO2, or in other words you can say there is a hypoxia. Okay, there is a hypoxia. Alright. Now what is the response to hypoxia? There will be hyperventilation, correct? Now when there is a hyperventilation, okay, what will happen? What about the carbon dioxide? There will be a washout of carbon dioxide, correct? So what will happen to the PaCO2? There will be a decrease in the PaCO2 because of the hyperventilation. Okay, because of the hyperventilation. Now, when there is a carbon dioxide washout, tell me what is the acid-base abnormality that is going to happen? You are likely to get a respiratory alkalosis. Respiratory alkalosis. Correct? So, decreased PaO2, decreased PaCO2 and respiratory alkalosis. Okay? So, there is hypoxia and there is a carbon dioxide washout, there is respiratory alkalosis. So, it is all because of this man, this problematic air trapping. That is what results in all these abnormalities. So, when an emphysema progresses, you tell me if you have watched the respiratory failure module of mine, what type of respiratory failure will happen here? This is going to be a type 1 respiratory failure, correct? This is going to be a type 1 respiratory failure. Okay, now this is very, very important, okay, because your emphysema results in type 1 respiratory failure. Now what about chronic bronchitis? We will see that shortly, but always keep this in mind. Emphysema, it is going to be a type 1 respiratory failure. Okay, very clear. So this is what happens in your emphysema. Okay, clear. Now having understood that, let's go a bit more regarding what is exactly happening and why this air trapping is happening. Okay, I'll just show you a picture. Okay, just relax. We are just going to understand this picture. So on this side, left hand side, both above and below is a healthy alveoli, and here it is a COPD patient. Okay. So the upper two are the inspiration and the lower two are with the expiration part. Now you can see here, this is the alveoli that you are having here. Okay, this is your alveoli, and this you can see is the lumen, correct? And you can see the smooth muscles in the lumen as well. And what you are seeing, these are the alveolar septa, okay, or the alveolar attachments. Now normally to keep the airway open, you have got to have a traction by these alveolar attachments. Okay, the alveolar attachments are very important to keep the alveoli open. Okay, very important. But what happens is that in case of COPD, what happens is the alveolar attachments are disrupted. Okay, because along with destruction of your alveoli, the alveolar attachments are also destroyed, because of which what happens is you can see the airway lumen. In inspiration, what should happen is that the airway should be open, and the air should be coming in. So you can see it is not as wide, the lumen is not as wide as in a normal individual, it is slightly narrow. So there is some sort of a mucosal inflammation and a peribronchial fibrosis as well, and the lumen is slightly narrow. Okay, so that is in case of inspiration. Now remember, we are more concerned about the expiratory part because we have got to understand what is this air trapping. Normally, inspiration, air came in, expiration, air has to go out. But what happens is that normal individuals, the alveolar septi or the attachments are there. So air is coming in and then air is going out. But since the alveolar attachments are damaged, at the time of expiration, what happens is that the airway lumen will collapse. The airway lumen will collapse. You see here, and what happens when the airway lumen is collapsed? The air gets trapped. Did you understand? Are you with me? See, the air came into the alveoli which was damaged by the disease process. The air was coming in, but when the air was about to leave, since all these alveolar attachments are already destroyed, it has already coiled back to a stage where the lumen is nil. You don't have an actual lumen, and because of which air is not able to go out. So there is a hyperinflation that is happening. And this type of hyperinflation is referred to as what? Is referred to as the dynamic hyperinflation. Dynamic hyperinflation. Now what is this term, man? Dynamic hyperinflation. What is this? It just means, see, the hyperinflation is a dynamic process, that it is in the expiration phase that the actual problem happens and there is air trapping. Okay, so that is what happens. So did you understand now by this simple picture, compared to a normal individual, why air trapping occurs in case of your emphysema? Very clear? Alright. Now I'll take you back to where we left, okay, the gas exchange abnormalities. Now one point that you have got to know in addition is that whenever you have hypoxia, what will happen to the pulmonary vasculature? There will be a pulmonary vasoconstriction. Pulmonary vasoconstriction, because we know that whenever there is hypoxia, the pulmonary vessels will constrict. Pulmonary vasoconstriction. So such a pulmonary vasoconstriction, if prolonged, will lead to what? A big problem. Pulmonary hypertension. Pulmonary hypertension. Now, long-standing pulmonary hypertension in an individual with emphysema will lead on to what? It will lead on to another problem, that is your cor pulmonale. Okay, cor pulmonale. Okay, it will lead on to cor pulmonale. So there is a right ventricular dilatation and dysfunction happening, and there will be a cor pulmonale. So are you very clear on what has happened in this patient with emphysema as the disease progressed? You've got a pulmonary hypertension, you've got a cor pulmonale. So which means that COPD or your emphysema is a disease that will gradually progress. Okay. So not only is it affecting the lung parenchyma, it has its effect on the vasculature as well. Okay. So this can happen. Very clear up to this much. Okay. Now, just to make a comparison, okay, of your emphysema, okay, with chronic bronchitis, because as of now we have discussed pure emphysema. We are going to compare it with bronchitis. You first of all just have a look at this picture now. We will come to it, okay. See, what is mentioned here is that in emphysema, okay, the right of this is regarding a pure emphysematous change, what happens in the airways. Left is what happens in a chronic bronchitis, okay, just to make a comparison. Emphysema, you can see all these alveoli getting dilated, respiratory bronchioles, there is a dilatation, air trapping, all that stuff happens in emphysema. Now what difference happens in chronic bronchitis? Okay, that is what we are going to learn. Now in case of chronic bronchitis, it is predominantly the region of your bronchi that is involved. And let's see what happens, what are the changes happening, okay. So this is just a diagrammatic representation showing the various changes in a case of chronic bronchitis. Now this is quite different from that of an emphysema, so you must pay attention, because in chronic bronchitis, what happens is that there occurs, you see here, this is the alveolar cells, I mean the bronchial epithelial cells, which are lined by the pseudostratified ciliated columnar epithelium, and I hope you can see the cilia as well. Yes, all these cilia also you can see. Now in case of bronchitis, what happens is that the same cigarette smoke will cause some irritation of this cilia in your the surface of the bronchial epithelial cells, and when there is an irritation by the cigarette smoke, it can cause a mucus secretion, okay, excess mucus secretion. So there occurs a goblet cell. How does that happen? There occurs a goblet cell hyperplasia. There occurs goblet cell hyperplasia, okay. So which in turn results in increased mucus production, and there also occurs other changes like a squamous metaplasia. But remember that the basement membrane will not be thickened, okay. In your asthma, you remember in that module I told that the basement membrane thickening will be there. There will be increase in the smooth muscles of the airway, but here none of that changes is happening, but it's predominantly a mucus hypersecretion, and there will be excess of neutrophils in the sputum. There will be a squamous metaplasia, no basement membrane thickening, and there is little increase in the airway smooth muscle, okay. So you can see the mucus gland hyperplasia and goblet cell hyperplasia, okay. So are you able to see, something that is given in yellow? Just see, when there is a ciliary damage, there is goblet cell hyperplasia, there is accumulation of these mucus, and because these cilia are damaged, it is not able to clear off this mucus as well, okay, because normally you have a very efficient mucociliary escalator mechanism. I am sure you would have heard of this in your physiology lessons. There is a normal mucociliary escalator mechanism, okay. So in normal case, this mucus would have been taken off, but because there is a chronic bronchitis and there is a slight irritation and destruction of the cilia, the mucus accumulates. So what is that major change that you are seeing in chronic bronchitis with respect to your emphysema? You are seeing that there is some mucus accumulation, or in other words, you can say that in the airways which are inflamed. So what are you going to see? In the inflamed airways, okay, inflamed airways, because this is a chronic bronchitis, this is inflammation. Inside the inflamed airways, you are seeing mucus plugs. You are seeing mucus plugs. Okay, so that is what happens in chronic bronchitis. Do you see how different it is from your emphysema? Though it falls under the COPD umbrella, you see how this domain is slightly different. Now let me take your attention back to this picture. Now what I am going to do is, I am just going to tell you what are the gas exchange abnormalities that can occur in a chronic bronchitis. But to make you understand this, I must tell you what is happening at the level of the respiratory unit. So you see here, it involves the larger airways like the bronchi. As I said, mucus hypersecretion, inflammation, there is bronchitis. And the smaller airways also it is involved. There is a chronic bronchiolitis, there is an airway obstruction. So what happens is that in case of chronic bronchitis, you will have these mucus plugging. Okay, so all these, the inflammatory mucus will be plugging in this in these airways, and sometimes even smaller airways also the plugging can happen. Okay, at the level of bronchioles. Now when plugging happens to the airways, suppose the plugging has happened here. Okay, the plugging has happened here. Then what will happen is that air is not able to enter the subsequent smaller units which are your alveoli. Okay, so it is almost like that particular part of the respiratory unit is cut off. Okay, it is cut off. So because of that, air is not able to enter. So you tell me, first of all, air not able to enter a particular part of the respiratory unit, what happens is that there is a decrease in the PaO2, or here also you will get hypoxia. Okay, here also you will get hypoxia. Now because the air is not able to enter that respiratory unit, the alveoli there, they would be actually collapsed because they are not working. So nor will the air enter, nor will the air come out through that also. Okay, that is from the capillaries. Because of which there is efficient gas exchange is not taking place there. That is, your carbon dioxide is not coming out also. So because of that, what will happen? Is it going to be a decreased PaCO2 like in the emphysema? No. It is a carbon dioxide retention, and you will get an increase in the PaCO2. Or you can say there is a carbon dioxide narcosis. So there is a CO2 narcosis that is happening in this patient. So decreased PaO2, increased PaCO2, that is a carbon dioxide narcosis happening. Okay, alright. So this is what happens here. And when there is a carbon dioxide accumulation, you tell me what is the acid base abnormality that you are expecting. There will be respiratory acidosis. There will be respiratory acidosis. Correct? Alright. So there occurs respiratory acidosis. And here also, since there is a hypoxia, in such a scenario also you will get what? You will get a pulmonary vasoconstriction. Pulmonary vasoconstriction. There can be pulmonary hypertension. And here also you can have a cor pulmonale. Here also you can get a cor pulmonale. Okay. So these are the changes that are happening. Very clear. So this is about the gas exchange abnormalities in case of chronic bronchitis. Okay. You see here what type of respiratory failure will happen if a chronic bronchitis progresses. Remember, it is decreased PaO2 and increased PaCO2. So remember, chronic bronchitis is likely to have a type 2 respiratory failure. Okay, type 2 respiratory failure. So if you have not watched my module on respiratory failure, please go back and watch. In that particular module, I did not tell you the difference between the emphysema and the bronchitis, just to make things clear here. So I hope now you know that in emphysema it is type 1 respiratory failure, chronic bronchitis, it is type 2 respiratory failure. Okay. So you see how different these two entities are, and I hope each and every one of you conceptually understands this topic. Now, conceptually understanding a topic means after listening to this module now, if after another 2 days you must be able to tell to someone in a simple language what is the difference between emphysema and bronchitis. Okay, I know that you know the points, but again, the more you know about a topic, I feel the more simplified you can, okay, to teach to someone. So you understood this topic means you are able to tell to someone also. Okay, so just after this module also, just another 2 days later, try recollecting, maybe teach someone also this difference between emphysema and chronic bronchitis. Now, just to make a comparison between chronic bronchitis and emphysema, so this one also I have taken from Robbins' textbook, okay, on the difference between bronchitis and emphysema, because it is given nicely in Robbins, the differences. See, bronchitis 40 to 45 years age group, emphysema slightly older age group. And remember, dyspnea as a manifestation, okay, the breathlessness occurs slightly earlier. Okay, the dyspnea occurs earlier in case of emphysema. Okay, because that is where you have the air trapping and the work of breathing is more, because you have a more hyperinflated lungs. So because of which early and severe dyspnea you usually get with emphysema. Bronchitis, the dyspnea component is slightly mild, but you have other problems associated with bronchitis. Now, in case of bronchitis, you must know that the patient has early copious sputum. Now, this is a very, very important feature to differentiate a bronchitis and emphysema. Because in emphysema, you are not getting any sputum production. But bronchitis per se, if you are asked what is the definition of chronic bronchitis, see, in chronic bronchitis, someone is having a chronic cough, okay, and this particular cough, this productive cough, is lasting for more than 3 months, okay, for 2 consecutive years. That is when you diagnose chronic bronchitis, because it has got to, there has to be an evidence of a chronic airway inflammation. So it is going to be a chronic cough for 3 months, more than 3 months for 2 consecutive years. And remember, the nature of sputum in case of chronic bronchitis, it may be mucoid, it may be mucopurulent, it can be purulent. Why? Because initially there is a goblet cell hyperplasia and there is mucus production, mucoid. But then what happens is that your ciliary mechanism is very much defective. You agree with me? And because this mucociliary mechanism is very much defective, there is a good chance that the individual can be very much prone to infections. So a patient with chronic bronchitis may experience recurrent infections, and because of the infections he might have a purulent sputum also. Okay, very clear. So infections are common in case of bronchitis. Remember, impaired mucociliary clearance. Yes, emphysema also you can have, but compared to chronic bronchitis, it is less likely. Now, respiratory insufficiency, that is going to a respiratory failure, is more in case of chronic bronchitis, whereas it occurs but towards later stages in case of emphysema. Because in emphysema, there is always a compensatory response. You have a hyperventilation, and you remember it is a type 1 respiratory failure that happens. And core pulmonale, again, more chance of a core pulmonale is with your chronic bronchitis. It can occur very well with your emphysema, but more chance for a chronic bronchitis. So airway resistance is increased in bronchitis, whereas it is normal or slightly increased in emphysema, because the airway problem is more pronounced in the larger airways, like in your bronchi when there is an inflammation. And elastic recoil is normal in case of bronchitis, whereas emphysema is the condition where your alveolar walls are damaged, so because of which the recoil is very poor. And chest X-ray, the hyperinflation is prominent, because I am sure that you very well know that the X-ray of a patient with a typical emphysema is that of a hyperinflated chest. Okay, this is a hyperinflated chest, and you can see the heart is again slightly a tubular heart, and because the chest is hyperinflated, you can see the dome of the diaphragm is slightly flattened. So you will get a flattened dome of diaphragm. Okay, and this type of hyperinflation is more common with what? It is more common with your emphysema. Okay, so such as chest X-ray is more likely to be in a emphysematous change rather than a chronic bronchitis. But remember what I already told you, a particular individual may have pathological changes of emphysema and bronchitis in the same individual, because naturally the triggering factor is the same, that is your cigarette smoke. Okay, alright, so you will have a hyperinflated chest here, and then so hyperinflation is prominent here, and you see here the vessels are very much prominent in case of a bronchitis. Okay, the bronchoalveolar markings are slightly more prominent. And again, this is something I'd like to discuss. A patient with a chronic bronchitis is called a blue bloater, whereas one with emphysema is called a pink puffer. What is this blue bloater, pink puffer? Let's see that. I'll just show you a picture. See, this is somebody who is a pink puffer. This is somebody who is a blue bloater. Okay. So what do I mean by this? See, pink puffer occurs in someone where the emphysema is the dominant pathology, and blue bloater occurs in chronic bronchitis patients. Okay, that is, in case of emphysema, what happens is that this particular individual, he will be lean. Okay, he will be a lean individual. Okay, yes, he'll have the barrel shaped chest. Okay, lean individual is there, he is having maybe a barrel shaped chest because of the emphysematous change, and the leanness is because of the systemic inflammation that occurs in a in an emphysema. So I'll come to that. What is this systemic inflammation in this COPD? We'll come to that. But for the time being, understand that he is very much lean and he's having a barrel shaped chest. So in case of the chronic bronchitis, what happens is that there is more chance of cyanosis, because you know that the respiratory compromise is more with your chronic bronchitis. So the chance of cyanosis is more. The respiratory failure, going into a respiratory failure is also early in case of a chronic bronchitis. So he will be someone who is actually having a cyanotic look. Okay, he's having a cyanotic look. Okay, and understand that he might be slightly obese. Okay, so in this particular individual, the systemic inflammation component is not that prominent. It is more prominent in emphysematous change. But here the individual will be slightly obese. Obese probably because his activities of daily living are very much limited and he is very much obese. The other one, it is probably the systemic inflammation contributing to his leanness. But this look, the cyanotic look, is very important. That will help you. Probably, since this is in this particular case of a blue bloater, it is not the very typical blue bloater, because in blue bloater sometimes you can have the cyanosis very much appreciated in the lips, which is not much appreciated here. All you can appreciate here is that this man is slightly obese, he is breathless. Okay, so that is it. Now in these entities, your pink puffer and blue bloater, these terms please keep in mind, it may be asked for your exam. Now let me just at this juncture, let me tell you some of the important examination findings in case of a COPD. First of all, let me tell you, in the general examination, I would like to tell you something that is not there. Okay, clubbing is usually not a feature of COPD. Keep that in mind. Clubbing is usually not a feature of COPD. If clubbing is there, you must suspect some other disease, maybe a lung malignancy, okay, maybe a tuberculosis, maybe a interstitial lung disease. So clubbing is usually against a chronic obstructive pulmonary disease. Okay, that is very, very important. And on inspection itself, you probably can see something that is known as a pursed lip breathing. Okay, that is patients with your COPD may have a pursed lip breathing, like, so you have a pursed lip breathing. So the purpose of this pursed lip breathing in case of COPD, okay, sometimes the typical attitude that is described is patients with COPD would sit like in a tripod position with his hands forward, and he would slightly lean forward, and so he is making that tripod position. You call it the tripod position, okay, and there is a pursed lip breathing. Now this pursed lip breathing is an attempt by the patient to increase the intra-alveolar pressure. It's an attempt to increase intra-alveolar pressure, because you know that there is, in case of your COPD, there is it is an obstructive airway disease. The problem is with expiration. So as to attempt to increase the intra-alveolar pressure and somehow get the alveoli out, the air out, he is going for the pursed lip breathing. He'll have a tripod position also. And on the inspection, you will very well appreciate that this person has got a barrel-shaped chest. Barrel-shaped chest. And what is this barrel-shaped chest? Normally, you have the transverse chest diameter that is more than the anteroposterior diameter. But in case of your COPD, you will have the anteroposterior diameter which is equal to or maybe more than the transverse diameter. So you will get a barrel shaped chest, and also you can get bilateral V's. You may get bilateral V's, but sometimes because the airways, because of the constriction of the airways, you will get V's. But sometimes if the airway is too much inflated, there may be a stage where you are not able to listen to the breath sounds at all. Okay, so you will not be able to appreciate the other added sounds as well. Okay, so these are the examination findings that you should look for in patients with a chronic obstructive pulmonary disease. And just another cartoon which I have seen from somewhere, okay, on chronic bronchitis, is just for your ease. Okay, I have not made this. Okay, so chronic bronchitis and emphysema. You see, this is the blue blotter. Okay, this is the blue blotter, and this is the pink puffer. Okay, so you see here the person is overweight and cyanotic, and because of the cyanosis there is elevated hemoglobin, there is a peripheral edema, you can have rhonchi and wheezing. But here, he will be severely dyspneic, because I told you the dyspnea component is more with your emphysema. He is slightly the older age group. He is very thin. He is having a barrel shaped chest because more of a airway air trapping occurs in emphysema. So he'll have a quiet chest sometimes because of too much inflation. The air is not going to come in and out. See, for you to auscultate the breath sounds, you should have that airflow in the alveoli, So what happens is that in case of emphysema, if there is too much of air trapping, sometimes you may not be able to appreciate the breath sounds well. Okay, so this picture I thought will help you to to get this in your mind, the difference between a blue blotter and a pink puffer. Clear? So we have seen that also. Okay, and yes, now if you are asked what is going to be the investigation of choice for a COPD patient, well, you can do spirometry, but always I would say the investigation of choice will be a CT thorax. Okay, it will be a CT thorax where you are able to appreciate in case of emphysema, you are able to appreciate the emphysematous changes. Now let me ask you a question. Now what is the likely pattern here? You can see emphysematous changes everywhere, but it is predominant in the upper zone. So what is that type of emphysema? What is predominant in the upper zone? This is actually a CT thorax of a patient with a centriacinar or a centrilobular emphysema. Okay, centriacinar or centrilobular emphysema. So in the investigation part, you can go for spirometry. And what will you see in spirometry? The FVV1 by FVC ratio. So it will be less than 0.7. This is a obstructive airway disease. The ratio will be less than 0.7. So what about the residual volume? It will be more in what condition? Is it going to be higher in an emphysematous stage or a chronic bronchitis? Very simple now, right? Because you know there is air trapping more in case of emphysema. So the residual volume, the total lung capacity, okay, all this will be higher in case of the emphysema rather than a chronic bronchitis. Okay, but overall, you know, you will have a FEV1 to FVC ratio less than 0.7. Okay, all right. So you can go for your spirometry, you can go for a chest X-ray, you can go for CT thorax, you can go for an ABG as well, arterial blood gas analysis. You know that in case of emphysema, you are expecting respiratory alkalosis, and in case of chronic bronchitis, carbon dioxide retention, carbon dioxide narcosis, and you will get respiratory acidosis. Okay, and you remember I told you this chronic obstructive pulmonary disease, you might have systemic inflammation, which is more prominent in your emphysematous subtype. What is that? See, I told you this COPD is a chronic inflammatory disorder as well. Okay, this is a inflammatory disorder as well. Now, when something is an inflammatory disorder, you will have a release of what? Cytokines. Correct? Okay, cytokines are released. Now, these cytokines and other inflammatory mediators would cause effects at multiple organs and organ systems. So, which means COPD is not just a pulmonary disorder, it is a systemic disorder. That is my point. Okay, you see here, when there is inflammation in the lung that occurs in COPD, and this inflammation will result in something that is known as spillover inflammation. Okay, which means the inflammation will involve other organs as well, not just the lungs. So it can release various cytokines like IL-6, IL-1 beta, TNF alpha, resulting in involvement of the kidney, your heart, everything will be involved. So you can have ischemic heart disease, heart failure. In the bones, it can affect osteoporosis. It can predispose to diabetes and metabolic syndrome, anemia, depression, and you might also have skeletal muscle weakness and cachexia. Okay, so that's probably the reason why some person lose weight. Okay, and yes, it can sometimes predispose to lung malignancy as well. And always, who is our villain? Cigarette smoke. Okay, so by this slide, I was trying to tell you COPD is not just any pulmonary disease, it is a systemic disorder. Very clear? Okay. Now we have understood this disorder in good depth. Now what are we going to do? We are going to treat COPD. Okay, so next topic is treatment of COPD. So remember I told you to begin with that treatment of COPD, you have got the guidelines, that is your 2019 gold guidelines. Okay, now what is this gold? It is the Global Initiative for Obstructive Lung Diseases. Obstructive lung disease. So remember, this is a very, very important guideline. So if you are asked somewhere regarding the treatment of COPD, your answer should start with 2019. Okay, as currently the guideline is the 2019 one, 2019 gold guidelines. That is what you have got to quote. Okay, so this is it, the Global Initiative for Chronic Obstructive Lung Disease, that is gold. So remember, if you have watched my asthma module, I have talked about the GINA guidelines in asthma. So here it is about the gold guideline. Okay, all right. So we are going to see about these guidelines. So we'll try to summarize this and make it very simple for you. okay, so that you can learn it. Okay. Now, first of all, this is what the guideline says. So, I will be showing you some of the screenshots from the actual guidelines, okay, so that you understand how and they are what is the message they want to convey to you in these guidelines. So, I will be showing you the flow charts as well. Now, what is the goal of treatment of COPD? So, the GOLD guideline says that there are two predominant goals. One is to reduce the symptoms and second is to reduce the risk of exacerbations. Okay, because the patient, when he comes to you, he will be having some symptoms. Your job as a physician is to treat the symptoms, at the same time to make sure that he does not develop further exacerbations. Okay, so to reduce the symptoms, you have got to relieve the symptoms, you have got to improve the exercise tolerance, and you have got to improve the health status. And to reduce the risk, you have got to prevent the disease progression, you have got to prevent and treat the exacerbations and try to reduce the mortality. Okay, so these are the goals, okay, the two important goals of treatment of COPD. Very clear? Okay. Now, the first point you have got to know is that the GOLD guidelines categorizes patients with COPD based on the severity. Now, how do they categorize? They categorize into 4 groups: GOLD 1, GOLD 2, GOLD 3 and GOLD 4. So, previously for the grading, the severity, there was another index by name board index, okay, but currently it is the GOLD index that you have got to follow. Now, this GOLD index, the GOLD 1 is the mild variety, where the FEV1 is more than or equal to 80% of the one that is predicted. GOLD 2 means it is 50 to 80%. FEV1 is 50 to 80% of the predicted. GOLD 3 means it is 30 to 50% of the predicted. And GOLD 4 is FEV1 less than 30% of predicted. So, you have got to categorize. After the pulmonary function test, you have got to categorize the patient as GOLD 1, 2, 3 or 4 to ascertain the severity of the patient. Okay, all right. Now, next let me tell you, for assessing the symptoms, okay, for symptom assessment, you have got 2 tools with you. Okay, for symptoms, you have got 2 tools. It's nothing but a questionnaire. One is the MMRC questionnaire and other is the CAT questionnaire. Okay, MMRC and CAT questionnaire. Now, what is this questionnaire and is it important to understand? Let us see. See, this one is the modified MRC dyspnea scale. Okay, this is nothing but a questionnaire which is given to the patient to grade his severity of symptoms. So, you have a grade 0 to grade 4. It is like grade 0 means he is getting breathless only with strenuous exercise. You also have the grade 1, 2, 3 and 4. Grade 1 means while he is hurrying on the level ground or while he is going an upslope, he develops a breathlessness, that is grade 1. Then you have grade 2, grade 3 and grade 4 in the increasing order of severity. Okay. Now, this you need not by heart for your exam because it is very less likely that they are going to ask you what is MMRC grade 3 or 4. But to understand this terminology is very important because this is used in the treatment. I will come to that. Okay, so for your exam, definitely if you are doing your residency in medicine, this is something you have got to learn. But otherwise, what you have got to understand is this is the grading that is used. Okay, now keep this in mind. This is based on the increasing severity. Okay, this is based on the increasing severity. The other one is a CAT assessment, which is a COPD assessment test. COPD assessment test. Okay, now what is the COPD assessment test? It's again some questionnaires where the patient is asked to put scores for himself. That is, I'll tell you one example. We are having 8 parameters here. 1, 2, 3, 4, 5, 6, 7, 8. For example, there is one parameter here regarding cough. So you have scoring from 0 to 5 for each parameter. 0 means he has never had cough. 5 means he has cough all the time. So he can put on a scale of 5 a particular score. He might put a 3 score, he might put a 4 score. So he is supposed to put the scores for this. Okay, so which means the maximum score can be 40. 40, you have got 8 parameters with a score of 5. So in a patient with COPD, GOLD says that you have got to measure the MMRC and your CAT assessment. Why? That is what we are going to learn. Why this scoring is because this is important for the severity grouping of COPD. What is important? Your MMRC and CAT is important for severity grouping of your COPD. Why should I learn the severity grouping of your COPD? Because as per the GOLD guidelines, treatment is based on this grouping. So how do you group it? There is a group A, group B, group C, group D. Very simple. Okay. Remember what did I tell you? The MMRC and the CAT were based on what? Symptoms. So you have 2 boxes here. One is where your MMRC is 0 to 1 and your CAT score is less than 10. And the other in which the MMRC is more than or equal to 2 and your CAT is more than or equal to 10. Or the CAT is more than or equal to 10. So you tell me A, B, C, D. I have grouped like this. So this is the left hand side. Okay, this is the right hand side. So you tell me one who has more symptoms will come in which side, left or right? Right side. Right side, because that is where the symptoms. So whenever you have MMRC more than or equal to 2 or you have your CAT more than or equal to 10, the score, you say that the patient has got high symptoms. High symptoms. Okay, that is high symptoms. When it is other way around, when the score is 0 to 1 or the CAT is less than 10, it is low symptoms. Okay, that is it with symptoms. Now keep it in mind. Be with me. Things will be clear in the next 2 minutes. Now, remember, along with symptoms, you are seeing something that is known as risk. What is this risk? Risk means it is based on the exacerbations of the patient. Because COPD can have exacerbations. Suppose he has had 0 to 1 exacerbation. You will put it in one column. And more than or equal to 2 exacerbations or 1 or more exacerbations with a hospital admission, you will put as a high risk patient. Okay. So this is high risk. This is low risk. Okay. This one is low symptoms. This is high symptoms. Which means when you have A, it is low risk, low symptoms. B means high symptoms, low risk. C means low symptoms, high risk. D means high symptoms, high risk. A, B, C, D. Very clear. Very, very simple. Okay. Simple tabulation. Okay. So once you have understood that there is such a grouping, you have got A, B, C and D, and C your D, not C your D. You see there is a D here. Okay, the D1, the high symptoms, high risk, he is very dangerous. He has got high symptoms and a high risk also. Keep this in mind. Okay, he is the one for whom we need aggressive therapy. Now let's come to the GOLD guidelines on the pharmacological treatment. How are you going to treat? Okay, you see there is a group A, group B, group C, group D. Now, first of all, let me tell you one of the major change in COPD as per the GOLD guideline is that they said that isolated use of inhaled corticosteroids is not that advised. Okay, isolated use of, that is repeatedly using inhaled corticosteroids. You remember it was so much advocated before, because whenever a patient with a COPD would come with an exacerbation, you would go for a nebulization with a steroid. But it is now said that if you do like that, there is an increased chance of recurrent infections, and probably you are increasing the chance of a mortality risk as well. Okay, so do not go for isolated inhaled corticosteroids. Then what do? You remember the groups, no? Group A, B, C, D. Group A management is simple. Any bronchodilator. Any bronchodilator you like, you can give it in group A. Okay, any bronchodilator. It can be, say, a long-acting beta agonist. It can be a long-acting muscarinic antagonist. So it can be anything. It can be a short-acting beta agonist. Any bronchodilator you give in group A. Group B means you will go for a long-acting bronchodilator. It has to be long-acting. Okay, that is either a LABA or LAMA. So LABA is your long-acting beta agonist like your formoterol. Okay, and LAMA is your long-acting muscarinic antagonist like your tiotropium. Okay, so either you go for a LABA or LAMA there. Group C, it is LAMA. Group C, it is LAMA. Group D, you remember the one. Group D, maximum problem, high symptoms, high risk. In such individuals, you have options. You can go for LAMA, either LAMA alone, that is your long-acting muscarinic antagonist, or you go for a LAMA plus LABA combination, or you go for an inhaled corticosteroid plus LABA combination. Now, remember that in Group D, you will go for the LAMA plus LABA combination when the patient usually has a CAT score more than 20. Okay? And similarly, you will go for a LABA plus ICS combination if the eosinophil count, okay, you are going for the blood eosinophil count, if it is more than 300. So there the decision whether the patient is on LAMA alone, I am talking of group D, LAMA alone or LAMA plus LABA or LABA plus ICS depends on certain other parameters. If you have a higher CAT score, you will go for a LABA plus a LAMA. Then if the eosinophil count is more than 300, you will go for inhaled corticosteroids. Now sometimes if the eosinophil count is more than 100, okay, that is in the 100 to 300 range, even then you can think of adding an inhaled corticosteroid, provided he has had previous exacerbations and hospital admissions. In that case you can consider, but the maximum evidence is when you start it for a eosinophil count more than 300. Okay, so I hope that is clear. Group A, any bronchodilator. Group B, a long-acting bronchodilator. Group C, LAMA. Group D, you have three options: LAMA, LABA plus LAMA, or LAMA plus inhaled corticosteroids. Okay, so these are the options that you have. Now remember, even if the patient is group C, okay, you start with LAMA. If it is not controlled with LAMA, you can think of adding a LABA also. Okay, and if it is not controlled, you can think of adding a inhaled corticosteroid also. Okay, so it doesn't mean that you should strictly restrict your treatment to LAMA alone. You can add as per the patient response. But this is the overall general guidelines that you have to follow. Very clear? Now this should be very, very clear, because in the exam you have got to learn this. You have got to learn this. There is no other go. You've got to learn this table. Okay? Alright. So you have understood the management of COPD. So you have understood the treatment aspect, but let me tell you what are the other options that you have. In addition to this therapy, there is also a role for your long-term oxygen therapy, especially in individuals who are severely symptomatic and so much of frequent exacerbations and saturation is not very much maintained. So at home, with certain oxygenators, okay, there are certain devices, portable devices are there, so that can be kept at home. So you can go for long-term oxygen therapy, and this long-term oxygen therapy, which is abbreviated as LTOT, has been proven to be beneficial in case of your COPD. Okay, long-term oxygen therapy. Okay, and then suppose if it is a centri SNR emphysema and the emphysematous changes are localized to the upper lobe, in such cases, if it is not responding to a medical management at all, you can think of a lung volume reduction surgery. Okay, you can go for a surgical method. Okay, lung volume reduction surgery. Now this is mainly useful if the emphysematous changes are involving the upper lobe. Okay, so you have learned the treatment, the importance of LTOT, the lung volume reduction surgery, and remember, more than anything else, what is more important? Smoking cessation, which is very, very important. So you have got to give the patient advice regarding smoking cessation. Okay, and because if the patient is quitting of his own, it is good, but otherwise you might have to give drugs for smoking cessation like your varenicline or maybe your nicotine patches. You can have your nicotine nasal spray as well. So these can be used for smoking cessation. So all in all, about COPD, I think we have seen in detail regarding chronic obstructive pulmonary disease, your emphysema, chronic bronchitis, the management as per the GOLD guidelines. Now remember that this GOLD guidelines has to be adhered to. Remember, no more isolated inhaled or inhaled corticosteroids, and also the GOLD guidelines also says that even the oral corticosteroids, because I have seen many who have put the patient on oral corticosteroids to reduce the symptoms, but here again the problem is there is a chance that he might develop pneumonia and other infections. Now in case of COPD, is there any routine role for antibiotics? Unless there is no definite documented infection, there is no role for antibiotics in the treatment of a routine COPD exacerbation, unless he has got a definite infection that has probably triggered the episode. So I hope this topic COPD is very clear to you.